This webinar tonight will be focusing on providing an overview of central sleep apnea and its treatment options. We are pleased to have Dr. Robin Germany and Dr. Jordan Weiner as presenters. To get us started, I'll introduce Dr. Robin Germany, who is the past clinical assistant professor at the University of Oklahoma and the chief medical officer of Zoll Respicardia. She has been with Respicardia for over 15 years and is dual trained in heart failure and electrophysiology. Prior to joining Zoll Respicardia, she was the director of heart failure treatment and the medical director of the Heart and Lung and Vascular Clinic at the University of Oklahoma. Dr. Germany, I'll turn it over to you.
Thank you so much, Jamie. I'm very pleased to introduce my co-presenter here, Dr. Jordan Weiner from Valley ENT, who is agreed to join us here today from Scottsdale, Arizona. He's specialized in the treatment of obstructive sleep apnea. He's president of the Valley ENT and serves as a clinical assistant professor at the University of Arizona College of Medicine, Phoenix, actively involved in training students, residents, and sleep medicine physicians. And in addition, he's trained hundreds of physicians nationwide in hypoglossal nerve stimulation procedures for sleep apnea. He's a fellow of the American Academy of Otolaryngology, Head and Neck Surgery, and the International Sleep Surgical Society, where he's served as a lecturer, researcher, and invited panelist. His practice focuses on individual management of obstructive sleep apnea, offering a comprehensive range of therapies, including Inspire and Genio hypoglossal nerve stimulation. He's committed to developing personalized treatment plans tailored to each patient's needs. And that, I think, is a great segue for what we're going to talk about this afternoon. So, Dr. Weiner, thank you very much for joining us this evening. Just a brief statement about the remedē system. This is full safety information is available on the website, but I'm going to kick us off a little bit, just a background in the pathophysiology of central sleep apnea. We'll keep it a little high level, but why does it matter to an ENT practice? Well, there's new data out there that's showing that up to 20% of patients with sleep disordered breathing may have central sleep apnea. So if you look across the US in most sleep laboratories, about 3 to 5% of patients actually are diagnosed with CSA. But a recent study, and we'll go over this a little bit more later, shows that if you actually look at those hypopneas, up to 20% of patients will be predominantly central. So there's a growing appreciation that these patients may be diagnosed with obstructive, but are actually primarily central sleep apnea patients. Now, we're not going to go into the deep physiology here, but just a reminder, from a patient standpoint, when we talk about it, we just say the brain forgets to breathe, right? But it's really a carbon dioxide driven disorder. And patients essentially don't see that change in CO2 at an appropriate time. And so it's kind of like the thermostat, right? Either you're too hot or too cold. These patients either breathe too fast or they quit breathing or have very, very shallow breathing. And most often, central sleep apnea presents as Cheyne-Stokes respiration, but there's a different group of patients, and we are seeing more of them show up that have a primary brain issue, be it from sometimes from an acute illness, a stroke, a brain injury, that also have a different form of central sleep apnea, a more idiopathic form or a primary form. Now, why do people get Cheyne-Stokes respirations? Well, it's typically triggered by underlying disorders, because all of that's controlled by the carotid body. That's what tells you when to breathe and when not to breathe due to your changes in CO2. So these patients hyperventilate, they blow off all their CO2, and that delay then sets them up to have such low levels of CO2. They have these long pauses in breathing. That leads them then to go back and overreact again, and they hyperventilate, and the cycle goes on and on throughout the night. And if you look at the average AHI in these patients, it's between 30 and 45. And oftentimes these apneas are 25 seconds plus. So it can be almost half the night that patients with the severe category of central sleep apnea really aren't doing any breathing at all. And these are some of the disorders we most likely see it in. I think the classic is heart failure. And the mantra has always been these are the only patients that get central sleep apnea. Maybe now they've added atrial fibrillation kind of in your piqued interest, but we're actually seeing it in a much broader group of patients. So these are the typical ones, but we have some data that's been presented over the last couple of years. And if you look at these patients, they do have a lot of comorbidities, but only about 30% of these patients at the most actually have heart failure. It depends on which group you're looking at, a huge VA group. If you look at the CSA patients, only 16% of the patients diagnosed with CSA across the VA, so this was a huge study. These are just the ones with central. Only 16% of them had heart failure. So they didn't report some of the other metrics. But if you look at the Sleep Heart Health study, you can see here that in that study, again, fairly healthy ambulatory patients. There was diabetes, myocardial infarction, AF, but still not a lot of heart failure. So this mantra that only heart failure patients develop CSA is probably getting wiped out a little bit. This is what we think today based on the best data that we have, that patients with central sleep apnea, about 30% have primary CSA. We don't have a good cause for it. Another 27% is in heart failure. There's a good portion with AF and stroke. And these obviously all three of those comorbidities kind of overlap and can, maybe do you have a little bit of heart failure? Possibly. And we see it in HFpEF patients as well. Now, the primary risk factors for CSA do look quite a bit like what you might see with obstructive sleep apnea. It tends to happen in males, but there's even a higher predominance in males, and that doesn't go away post-menopause. But we're seeing an increasing number of women get diagnosed with CSA due to medications, and not just opioids, but things like baclofen, other centrally acting agents. Atrial fibrillation, age over 60, a lower ejection fraction, stroke, and then spinal cord injury, which is interesting but keeps popping up in the studies. Now, one of the most difficult things about CSA is that depending on which literature you're reading, the definition of CSA has not always been the same. So in fact, the ICSD actually describes it in two ways. Either you can have more central apneas than obstructive apneas, or you can have more central apneas and hypopneas than obstructive apneas and hypopneas. Okay, so two different definitions within the same. They seem like they would be the same, but as we look at some cases here in a little bit, you'll see that those can be really different definitions. The other is moderate to severe central sleep apnea. And this could be a central apnea hypopnea index greater than 15. Or it could be, this was the one used in the pivotal trial of phrenic nerve stimulation, an apnea hypopnea index of 15 and more central apneas than obstructive apneas. So again, this is for the moderate to severe category. But either of those can be used and have been used in literature. So let's talk a little bit about what it means if you do look at hypopneas. And we were talking about this a little bit earlier. Many sleep labs do not classify hypopneas. There's new software coming out that's going to probably facilitate this, but this is how important it can be in an accurate diagnosis. So this is from a French cohort. They have a very large database. They actually went back and classified all of their PSGs that were submitted to this database across multiple centers in France. And you can see here that when they looked at the original data, about 4.5% of their patients were predominantly central. And that is very much in line with what we see in the US. Most sleep labs are between 3 and 6%. But now when they went back and they took the time to classify the hypopneas, they had almost 20% that were predominantly central. And then they had another 19% that were above 25% central. So not predominant central, But you can imagine as you're talking to your patient and counseling them on which therapies, how that might affect them, these patients are going to be less likely to have a full response if they're only treated with something that treats obstructive sleep apnea. And the problem, right, with each of these episodes is it has the same downstream events. So you could almost put obstructive here. Probably I would say the one thing that is a little bit different, central sleep apneas don't have as much pressure changes because you're not trying to breathe, obviously, against a closed airway. But the rest of the downstream effects of central are very well documented now and are very similar to obstructive sleep apnea. So you still get arousals. The arousal occurs in a different place. So one of the distinguishing characteristics for central sleep apnea is that the arousal actually occurs at the peak of hyperventilation, not at the onset of hyperventilation. And that can be, even with hypopnea, is a really good clue that this is not an obstructive event, but a central event. But it's downstream, things like increased run-in, increased sympathetic activation, dementia, cancer, all of the same things that you're working on with your obstructive sleep apnea patients are the same as in central as well. And CSA does have a very unique relationship with cardiovascular disease. So cardiovascular disease may be the cause of the onset of the CSA because cardiovascular disease increases sympathetic drive. That increase in sympathetic drive is what changes the way that the carotid body and the peripheral chemoreceptors see those changes in carbon dioxide. So it delays that response to CO2, which allows then for the hyperventilation and the hypoventilation. But as CSA gets started, all of those downstream effects are going to increase the sympathetic drive, and therefore it can actually trigger new onset cardiovascular disease. And for a long time, we thought this only went one way, but we have good data now from the Sleep Heart Health study that untreated central sleep apnea doubles the risk for heart failure, doubles the risk for central sleep apnea, for atrial fibrillation, and can increase the risk for stroke. And in fact, in heart failure, all of the medications we use to treat heart failure are focused on decreasing sympathetic drive. But if you have a patient with central sleep apnea now, every minute of the night, they have a surge in norepinephrine. So it's negating all the great work we're doing now with all of our medications throughout the course of the night. So here are the increases in cardiovascular risk. As I said, we've got great longitudinal data from Sleep Heart Health, from Mr. Oz, from other cerebral vascular accident studies. And for me, again, my background is in cardiology. This is one of the most impressive ones to me. These are, and it's not labeled here, I apologize, somehow that got left off this side, but these are patients with heart failure that have implantable defibrillators. And that black line there are patients without sleep disordered breathing at all. And their average time to first appropriate shock is about 3 years. In patients that have obstructive sleep apnea, that's our blue line, they are definitely worse, and their time to first appropriate shock is about 2 years. And patients with central sleep apnea is our red line here, and the time to the first appropriate shock is 14 months. So these patients, if you look at by 3 years, they have about a 50% mortality. So CSA is a very poor prognostic indication in the heart failure population. And we have that not only in this study, which was out of Germany, but this study as well, which is an NIH study done at Ohio State University. And they just took hospitalized patients with heart failure and started screening them. They screened them in the hospital with polygraphy, not an in-lab study, and they followed those patients out to 3 years. And the number one predictor of mortality was central sleep apnea, obstructive sleep apnea just slightly right behind. So any of you that are gathering your referrals from cardiology practices, over 2/3 of patients with heart failure have sleep apnea. They need to be just testing seemed to change the prognosis in a follow-up study from this study. Um, and again, just reiterating that CSA itself increases heart failure readmission, and it can predict which of those patients are going to lead to a number of readmissions. 1 in 4 patients had at least 2 more hospitalizations within 6 months. So the problem with central sleep apnea is even if you identify it, it had traditionally has not had a lot of treatment options. So most of you that are joining us today may be looking more at advanced therapies. So up until 2017, there was CPAP, there was BiPAP, ASV. At the time could not be used in patients with lower ejection fractions. Some people would try oxygen and some different medications. But the data may be a little bit slight there, and we'll go over some additional data. But now out on the market is an implantable device called the remedē system, which is transvenous phrenic nerve stimulation. And that is now actually in the guidelines. So there are brand new AASM CSA guidelines that came out about December of last year. And these are now the treatments. So we're getting to the point where we have a number of treatments for central sleep apnea, just like we do for obstructive sleep apnea. Here you can see CPAP, BiPAP, ASV, depending on the device. There's a little bit of data for oxygen and acetazolamide in the correct patients. And you can see here that phrenic nerve stimulation is also listed. I'm going to spend just a few minutes here talking about the device itself because it may be new to some of you. It's indicated for moderate to severe central sleep apnea in adult patients. The only contraindication that it has is an active infection. And this is what it looks like. So I will tell you, it's a little bit bigger than the hypoglossal nerve stimulator. It has a lot of diagnostics in it, but it's a fully implantable system. It is implanted by an electrophysiologist in the EP lab, similar to a pacemaker. And the goal here is to actually stabilize breathing. So the lead is going to be put in next to one of the phrenic nerves, either the left pericardiophrenac or the right brachiocephalic vein, sitting right there next to that phrenic nerve, and it's going to stabilize breathing. One of the unique features about this system is that it turns on automatically at night. So there is nothing the patient does. There's no activator. The device knows what time it is. It knows when the patient is in a sleeping position. It's going to come on automatically, so there's nothing the patient has to do. And it was designed that way because these patients have a lot of comorbidities. They need something that is basically automatic. And it has a time feature, it has a position feature, and then it has a movement. It has an accelerometer in there that's going to know when that patient's moving. But if it comes on, they're not quite ready to go to bed yet, all they do is sit up or roll over, and that will suspend therapy. It'll give them a little bit of time to get back to sleep when they wake up. And this is what it looks like. So some of you may not be used to looking at all of this all the time. So we're not going to go through everything, but you can see here, this is a full PSG with the EEGs, the ECG, which is obviously scaled up, so it's difficult to read, but pay attention here on the left side. You've got oxygen, the airflow via nasal cannula, the abdominal and thoracic belts. And then at the very bottom of this is the actual stimulation of the device. So one other way that this really differs from at least the Inspire devices, it doesn't wait for the patient to necessarily have an apnea. The goal here is to stabilize breathing. So once it comes on in the night, it's going to stimulate at a constant rate. And you can see for this patient that it's coming on at 3.7 milliamps. And right away, you can see that there's now airflow with every event. But it's not quite even. And the device is going to look to see, is the patient breathing at the respiratory rate that we have programmed the device? And a common perception is that we would actually speed breathing up. But remember, this is a disease of hyperventilation. So we actually want to slow breathing down. So the goal of the therapy is to make slightly longer, slightly deeper breaths. and it's typically programmed below the resting respiratory rate. And then the device will walk up every 2 minutes, depending on if the patient is breathing with the therapy or not. So it's going to test every 2 minutes. If it's not there, it'll walk up to a set parameter. So something that's still very comfortable for the patient. And we call that the maximum. So here you can see every 2 minutes, the device walks up. And this is a real case, but most of the time that would continue on for a period of time. But here, this is a nice picture because the patient rolls and instantly the therapy cuts off, and this patient goes right back into Shane-Stokes breathing. So you can see the central come right back and the drop in oxygen that's associated with that. So that's the basics of how it works. Follow-up is very similar to what you may be seeing with your hypoglossal patients. It is not activated during the implant. We activate it about 6 weeks, so a little bit longer, just to give that transvenous lead a little bit of time to heal. They will come back usually once or twice over the next 3 months while the device is programmed specifically for the patient. And then oftentimes they'll have a sleep study at the end of that, and then they're followed realistically about every 6 months for most patients after that fairly quick visit. And a lot of diagnostics are in the device to tell you how it's working, which we won't cover today, but if you have interest, we can certainly set some time up to go through that in a little more detail. Now, a couple of important things is most patients with central sleep apnea also have obstructive sleep apnea. So it's important to realize that just because they have some obstruction, this idea of pure central sleep apnea, that's really rare. It does happen, but most of our patients have a combination. For the clinical study, there were two parameters. One is they needed more central apneas than obstructive apneas, and we did limit the obstructive apneas to no more than 20% of the total AHI. And why did we do that? Well, for the purposes of the clinical study, we couldn't add any treatment for obstructive sleep apnea for those patients, right? The therapy had to stand on its own. We're just wrapping up another study right now. Hopefully data will be presented in the spring meetings. And in that, we do have about 20% of our patients that now receive therapies both for obstructive and central sleep apnea, because these diseases often have similar risk factors, things like obesity, getting older, comorbidities. So that is very common. So it's important to know that central apneas are typically not 50% of the AHI, but they are more than 50% of the apneas. Or if you do classify, or the sleep lab you're affiliated with classifies hypopneas, then most of these patients would be predominantly central if the hypopneas were considered. Now with that, I'm gonna just remind everybody, if you have questions, comments, please put them in the chat. We're gonna keep going here. I think you can do the Q&A as well. And I would really like to kind of shift gears just a little bit and ask Dr. Weiner to come on and tell us a little bit about his experience and why he's now become much more aware and interested in central sleep apnea.
Sure. Thank you, Dr. Germany. Thank you for inviting me to speak here as well. As a sleep surgeon or just another sleep apnea specialist, it's really imperative that we are aware of the phenomenon of central sleep apnea because it's in many of our patients. And especially if it's primary or moderate to severe central, it's not necessarily going to go away with management of their obstructive sleep apnea. So we have to, like anything, if you don't think about it, you often won't find it, and it will hurt your results because you're going to have untreated central sleep apnea smuggled in to your obstructive patients you think are obstructive. So let's go on to the next slide. So I see a very large volume of sleep apnea patients. Believe it or not, I diagnose many patients with sleep apnea. Myself, I manage a fairly large cohort of CPAP patients as well myself, but I also perform a high volume of sleep apnea surgery. And so, I see a lot of, central sleep apnea. So it's important, as I said before, you have to think about it. And so as I'm seeing a new consult uh, with a history of sleep apnea, first thing I want to look at is how are they diagnosed? Was it a PSG or was it an HSAT? And if they have a PSG, of course, I'm going to look for the presence of central sleep apnea. We need to make sure it's, low. It's either mild or, not the dominant form of their sleep apnea. And if they didn't have a PSG, I think about the risk factors that Dr. Germany is going to actually has already covered for us tonight. That might be a clue that this is somebody that we need to be extra careful and make sure they don't have central sleep apnea. And if they do have one or more of those risk factors, obviously heart failure, atrial fibrillation, history of stroke, renal failure, then I will make sure that we either order a PSG or a suitable HSAT that has a known high accuracy of CSA scoring. And we're going to talk about that in just a little bit because HSTs vary tremendously in their ability to correctly detect central sleep apnea, and you have to know the technology that you're using to know whether or not it's a suitable screening tool for CSA. So don't hesitate to order a PSG if you're not sure about the technology that you're using at home, or maybe consider switching to an HSAT that is a good CSA screener. And if they do have CSA, is it moderate to severe? Or does it represent more than a quarter of their total AHI or AI, depending on your lab or home sleep apnea test? And those patients, I don't manage myself. That's the one category of sleep apnea that I will pass the baton because they have to be worked up further to look for potential causes. They may need to see cardiology as well. And if they have a ferritin, low ferritin or iron deficiency, then they may be treatable. But also, I don't want to manage it. This is a much more complex patient to manage with PAP therapy, whether it's ASV or BiPAP. And so I prefer in my community to have my sleep medicine colleagues manage it, especially ones that have an interest in central sleep apnea. Oh, so then the sleep medicine will do their CSA workup. Sometimes that's imaging of the brain with an MRI, obviously looking at iron and ferritin levels, and thinking about their heart status and whether or not they need to see a cardiologist for CHF workup and so on. And then they'll go ahead and treat the CSA if possible. And I don't know if we're going to cover acetazolamide tonight, but I'll just mention that this is an option that we do sometimes use for CSA because it basically increases the CO2 level in the blood. And as Dr. Germany said, that is the major driver of respiration. And so increasing their CO2 just a little bit, a couple of points, may trigger a greater ventilatory drive in patients who can tolerate it. And so that's sometimes an option. Or if the patient is PAP tolerant or PAP naive, they'll usually do a trial of ASV PAP, which is essentially PAP with a ability to deliver actual breaths at a certain rate. And if the patient is CPAP intolerant or not a candidate or didn't succeed with acetazolamide, then that's when they move to consideration of phrenic nerve stimulation, which we've just heard about. Once the CSA is successfully treated, and usually it is, particularly with remedē, then a new sleep study is done to see how much of their obstructive apnea, because as she said, most of the time they have comorbid obstructive sleep apnea, how much is still there following treatment of the CSA. And sometimes there's a lot. Sometimes it even increases after CSA treatment. And so if they still have moderate to severe OSA with control of their CSA, then they'll refer them back to me since they're PAP intolerant patients for pursuit of CPAP alternatives for their obstructive sleep apnea. And, we have had in Arizona actually a pretty good experience with combined remedē and Inspire, in fact. As of the last time we talked about it, myself and Dr. Rushir Patel, we had one of the larger series going of dual therapy patients. So we've had really, really good outcomes with these people. The CSA is really well controlled with remedē, and then they behave quite well with hypoglossal nerve stimulation as well. So for us, it's been a very good combination therapy.